Hello, pharmacology students. Another chat with Brat, and this is going to be our last chat for the semester. Can you believe we're at the end of the semester and we're almost done? So hang on, and we're going to talk about drugs to treat peptic ulcer disease. So when we're talking about drugs to treat peptic ulcer disease, one of the things that we have to think about is what are they doing? So if you remember, peptic ulcer disease is when you've got erosion in the lining of the stomach and sometimes in the intestines, and we need to protect that area from further injury. So what we're going to do with these drugs, we're either going to decrease GI activity with secreting certain enzymes and substances that are injurious to the stomach. We're going to try and block those secretions. We're going to help the stomach or the intestine to maintain or increase its mucus blanket, which really helps to protect the stomach. And we're going to replace some of the enzymes that the stomach needs in order for it to work appropriately. So let's take a look at the sites of action. Now, we're not going to be talking about these pancreatic enzymes, so that's not going to be on your exam, but we're going to be talking about proton pump inhibitors, and you can see where they work. These proton pump inhibitors end in all azoles. So when you see that, you can see there's a number of them, but we're going to talk specifically about omeprazole. And what these do is they work right in the stomach to basically stop the pumping of hydrogen ions into the secretions of the stomach. We're going to also talk about histamine 2 blockers, and we're going to talk specifically about cimetidine. We're going to talk about prostaglandins that work right here in the stomach itself, and we're also going to talk about antacids and also about antipeptic drugs. So those are the major classifications of drugs that we're going to be discussing. So if you look at these drugs together, and I'm just going to review quickly with you what some of the major actions are. So we'll talk again about cimetidine, and to remember those drugs, there's a number of them. They all end in tidine, T-I-D-I-N-E, and that's how I remember that this has something to do with the stomach because they are peptic ulcer disease drugs and has something to do with eating. So they work by blocking hydrochloric acid, and they also then can protect the stomach. We have antacids. We're going to talk specifically about sodium bicarb, and it basically helps to neutralize the pH in the stomach. We're also going to talk about proton pump inhibitors, particularly omeprazole, and these all end in prazole, and they act similarly to the histamine blockers, but a little bit different way. They block the secretion of hydrochloric acid into the lumen of the stomach. Another agent is the antipeptic agent, that's Sucralfate, and what this does, and this is really a cool drug, is that it really just provides what I call a blanket covering up that stomach ulcer, and we'll talk about that more in just a minute. And then prostaglandins, and the one we'll talk about is Misoprostol, and that inhibits the secretion of gastrin and increases secretion of mucus cells to protect the stomach. And again, it's buffering the stomach and protecting it from injurious enzymes. So let's talk first about cimetidine. Cimetidine is a histamine 2 blocker, and basically we use that for treating both ulcers, both duodenal and gastric ulcers. We see there's a couple other reasons why we might use that. And we talked about what works by inhibiting that histamine receptor and inhibits also the gastric acid secretion, and is also decreasing pepsin because these things are being too overactive, and it's injuring the gut. So these drugs don't have, this one particularly doesn't have too many side effects, except if you're a man. And you can see here down at the bottom the adverse effects that it can cause impotence and gynecomastia. And gynecomastia is enlargement of breast tissue, and you can imagine that these two are very problematic to a male. So if you have a male client, cimetidine is not a good choice, that there are other H2 blockers that would be more effective, like famotidine. So let's talk about antacids. So antacids act exactly what the name sounds like. They neutralize stomach acid. That's why they're against acids. So there's different types of antacids. They all have a different base. They have sodium, calcium, magnesium, or aluminum. And these are all found over the counter. But what we're going to use as our prototype is sodium bicarbonate. So sodium bicarbonate is basically, again, it's trying to neutralize the gastric acid. But the problem with sodium bicarbonate is that it can cause a problem down here with electrolytes. It can cause hypokalemia. It can also cause a metabolic alkalosis because we're adding all this sodium to the patient, and it can cause alkalosis. So this can be very problematic, particularly if the patient has kidney disease on top of it. So we try and avoid this antacid if possible, but if a patient is taking a lot of this antacid, it can really present some problems for a patient. So we need to be aware of this if patients are overdosing on sodium bicarbonate and get them to take a different antacid. So let's look at the proton pump inhibitors. Our prototype here is omeprazole, and omeprazole again is used for the same things, a duodenal ulcer, also a peptic ulcer. And basically what it's doing is it's really blocking this acid production, and it's decreasing overall the gastric acid levels in the gut. So a couple of things about this is that it's important that the patient swallows it whole. You don't want to break it. You want to break up the capsule and dump it in something for a patient to eat. It should be swallowed. We have to be very careful with pregnancy and breastfeeding, and very careful the patient is taking anything that's going to have anticoagulant properties like warfarin or aspirin. So make certain you do a health history and ask the patient about that. Some other things about these adverse effects here is if they're pretty mild. Some patients might just have some problems with cough or might be more prone to developing a respiratory tract infection. But for the most part, it is pretty easy to tolerate for the client. The next one is the antipeptic agent, and this is Sucralfate, and this is one of my favorite drugs just because I think it's so cool the way that it acts. But what it does is it just kind of acts like this kind of neat little kind of a Band-Aid, this gelatinous Band-Aid that kind of sits on top of that ulcer. And by doing so, it protects it. So it sits on that ulcerated area, and it forms this nice little patch over it, just kind of like what mucus should be doing in the stomach. And it then protects it so the stomach can heal. It can protect it from these proteolytic enzymes like pepsin, and it can be very effective to allow the ulcer area to heal. So these are really cool drugs, and they have very few side effects associated with them. So some of the side effects of the Sucralfate is that basically we just use it short term. It's not something that a person would use on a long-term basis. Sometimes it's really good, for example, during chemotherapy. Remember, chemotherapeutic drugs target rapidly growing and dividing cells, which is what the gut is. So this sometimes can be used for good short-term management of an ulcer that forms when someone's under chemo, and again, if they develop some esophageal erosion, for example, we talked about the drugs that are used to promote calcium retention in the bone. You have to, like Fosamax, you have to stay sitting up. If you forget to do that and you lie down, you can get some gastroesophageal erosion. This could be a good drug that would put a patch over that and help the client to heal. With this drug, the biggest problem is constipation and diarrhea. So these are the most common. And when you think about drugs that are trying to impact the gut with secretions, it makes sense that constipation, diarrhea, and indigestion are going to be side effects because it's basically drugs are altering the normal secretions in the GI system. Some contraindications to this is pregnancy and breastfeeding, just because of the fact that it can cause problems because it crosses into the breast milk and crosses into across the placenta. Some other things is that this has a problem here is that if you give it with antacids that have aluminum in it, it can cause toxicity. And so we have to stay away from antacids that don't have aluminum in it because this drug is going to prevent the aluminum from being absorbed, and it's going to then stay in the body. So the last drug we're going to talk about is misoprostol. And misoprostol is a drug that we use when patients are on nonsteroidal anti-inflammatories and anything along that line that is going to put that patient at risk for gastric ulcers. So what happens here is that it basically stops those secretions in the stomach. It increases the bicarbonate, which is really helpful. It neutralizes the pH. It also helps with mucus production. So basically, it's protecting the lining of the stomach, which is great, which we want it to do. But here's the caveat, that it also increases the effects in the uterus. So if any of those of you that have had a child, or you know something about this, that this is a prostaglandins. Prostaglandins are used to soften the cervix, and they can present problems. And that's one of the reasons why you have to be very careful that why a woman should not be using this, if she's pregnant. And this drug can be used in combination with another drug when a pregnancy wants to be terminated. So some of the adverse effects of this, as you can see here, are things such as a miscarriage and some bleeding and spotting, and it's because of what it's doing in the uterus. And that's why it's contraindicated in pregnancy and lactation. So that concludes our last lecture on peptic ulcers and the last chat with Brad for the rest of the semester. You have a great rest of the week and good luck on your final exam. Bye-bye now.